Good afternoon, everyone, and thank you for joining us for this event, which is our sixth dialogue in transforming health systems. Today's theme is on power politics and fiscal sovereignty and is urging us to think about what is the way forward for low and middle income countries and other settings that might have constrained financing. I'm very, very pleased and excited to have such a fantastic panel of speakers join us in person and online. But before introducing them, I've been asked to make a couple of very important announcements. The first is that after we've had the kind of panel discussion, there will be an opportunity to have an informal discussion. So please do join us on the seventh floor for some snacks and a little bit of networking. And there will also be a photo for our in-person attendees, a group photo if you would like to participate. It will just be outside this room. So now moving on to our speakers and to introducing them. We have three speakers online. We have with us Joe Kutzen, who is a very well-known health economist with over 40 years of experience working all over the world. For most of that time, he's worked with the WHO as their lead on health financing policy in the European region and then globally. Hi, Joe. Thank you for joining us.
Hi, thanks. Nice to be here.
We also have with us Professor Juliet Nabionga Orem, who is primarily a medical doctor, but also a health systems expert with experience spanning over 2 decades. She's published extensively in the areas of health systems and services, health financing, health economics, policy analysis, and in knowledge translation. At the moment, she's working with the WHO and is also professor in the Faculty of Health Sciences in the Northwestern University in South Africa. Welcome, Professor.
Thank you for inviting me.
And online, we also have Zubin Shroff joining us, and they are a technical officer at the Alliance for Health Policy and Systems Research, which is a WHO-hosted partnership that supports the generation and use of health policy and systems-related research to strengthen health systems in low and middle-income countries. Welcome, Zubin. Thank you for joining us.
Thank you. Great to be here.
In person, I'd like to welcome Professor Mishal Khan, who I've had the privilege of working with and knowing for several years. Mishal is a public health leader and has a lot of experience in providing strategic advice to governments, funders, multilateral organizations, and in shaping very high-stakes policy, governance, and resource decision allocations. She's a professor of global public health at the London School of Hygiene and Tropical Medicine, as well as visiting faculty at the Aga Khan University in Karachi. Welcome, Mishal.
Thank you.
Also welcome to Dr. Sumit Mazumdar, a senior research fellow in global health economics at the University of York. Sumit's research focuses on the political economy of health financing reforms, universal health coverage, and health systems in LMICs. His work combines health economic analysis with political science, institutional economics, and development studies to understand how power relations, institutional arrangements, and historical legacies shape health policy outcomes. And I didn't know this until 15 minutes ago, but actually Zubin and I have worked together almost a decade ago, but are only meeting in person for the first time today. And finally, we're very privileged to have Zil Audi-Poquelin with us. Zil is a PhD candidate at the LSE and is doing her PhD looking into the political economy of health financing reform for universal health coverage in low and middle income countries, focusing particularly on Kenya. So thank you very much for joining us. And I think what I'm going to do is jump straight into the questions that we have for our panelists. The first question is for Joe, and it's to get us kind of started developing a frame of reference for resource mobilization and fiscal transition. Joe, what do you feel contributes to progress on sustainable financing for health? How is this affected by the current geopolitical context? And what does this tell us about how we think through the respective roles of public and private funding sources in the future?
Hi, thanks for this. I think I'm going to answer this in 2 parts. One is kind of what many of you may be familiar with in terms of what I think many people in the world have been saying about what we know about what works for health financing for universal health coverage. And in brief, this is mainly about relying on public funding and in low and middle income countries on general revenues in particular. Because private financing takes the form of voluntary health insurance and out-of-pocket spending, we know these both have negative consequences. But I want to come back to other issues in private financing soon, but just to say that those are kind of our, the usual messages on health financing, plus others around reducing fragmentation, both for equity and efficiency concerns, improving the ability to match public funds to priority populations and services, which is another way of kind of saying, more strategic purchasing, better, more effective public financial management. And critically, on an aspect of what I would think of as sovereignty or, domestic ownership has to do with strengthening the use of data for decision making, right? And not just as a technical thing, but also thinking through the institutional arrangements that really link critical thinking and analysis to decision making based not on evidence from elsewhere, but evidence from your own domestic experience. So those are the general messages. And the challenges, not just in the current context, but really what we see is that the current context isn't new, but much more extreme, let's say, in terms of the challenges of public funding and what has happened to aid and so on. Getting more public money is going to be difficult. And, the fact that that's a reality doesn't suddenly magically make voluntary health insurance and out-of-pocket spending work. Okay. So, and in general, the health sector does not have a solution to the revenue problem. That's much more of a macroeconomic and fiscal issue. Of course, there are health taxes, but that's not primarily a revenue type of intervention. So I think the general recommendation on what we've traditionally talked about and what I'll come back to in terms of the recurrent financing of health services is to focus what you can do on pooling, purchasing, benefits, and institutions. But the second part, and really where I wanted to spend some time, is a bit of new thinking about more broadly, because what we in the health financing community think of as health financing is, as I said, more precisely the recurrent financing of health services. So what this doesn't address, and that might have more or different implications also for private financing, has to do with more upstream issues, that is before the point of delivery. And just to run through these briefly, to get through my comments, and also to say that we know private financing is happening in all of these things. It's not something that necessarily needs to be encouraged, but the way private financing is happening tends not to move systems closer to UHC and may move them further away. So let's talk about 4 specific areas. One is capital investment for health delivery system infrastructure. Now, for this, of course, there is private investment. I am skeptical on this one in terms of, private investment that is seeking a return, how that would support progress. Because if you're trying to do something like build health centers in remote rural areas, you not only have to do that, you can get money for that, but then you have to pay the recurrent cost. You need additional staff and drugs. And the question for government is, well, should we also pay a private return on top of that? Okay. And, if government doesn't pay it, then you don't really want to charge the users of that who are likely not able to pay. So this is why that type of investment has been much more to do around the scope of concessional financing, development loans, and so on. But there's another dimension, which is capital investment for the production of health inputs. And here, like medicines, medical supplies, vaccines, and so on. I'm much more optimistic about this. It is, of course, already happening as well, because every health system, even if you're predominantly publicly funded, you still need to procure medicines, supplies, and so on to deliver services. And the challenge is to do it better. Okay. So in principle, and this is something that has to be, can be improved, obviously, it should be possible to develop some type of partnership to do this where private investors can get some, whatever we mean by reasonable return, that's to be negotiated. And the system and the people, more importantly, get a sufficient supply of quality assured products at a reasonable price. So there's lots of shoulds and adjectives there, but and we learned during COVID that governments don't do a very good job of this. But this is where the agenda has to be. And the additional kind of, let's say, sovereignty dimension of this is not just about producing things for the health system. It's also jobs. It's also potentially growth. It's also reducing dependence on foreign sources of supply and so on. So it's not easy, but I think this is a promising direction that needs attention. Two other areas I'll just mention quickly because I don't know much about them other than to say they're separate boxes that need to be addressed. One is the recurrent financing for procurement and distribution of inputs to the point of service delivery. Some people call that supply chain financing. I don't have a great label for it. The thing is, that's a distinct area. And really what I've always tried to do in health financing is unpack terms and try to get the concepts right. And last, and maybe I don't know if I'd call it the elephant in the room, but a big one, and it's also about an input, but it's the human input, right? It's the financing of the production of health workers, nurses, doctors, and other health personnel. So I don't have strong priors really about public and private roles, but we want to get those boxes right so that when we're talking about financing issues, we're actually talking about, we're having something of a common language or a common concept. I think the broader message in all of this is that times are difficult now. It doesn't sort of change what we know about, recurrent financing of services, and maybe a way of summarizing what I would say in terms of the opportunities for private financing to contribute is that we certainly don't want to see more private health insurance, but we might want to see more private investment in medicine and vaccine production. Okay, so that's kind of a summary of those comments, and I'll stop there. Thanks.
Thank you so much, Joe. I think that moves us on to the next question, which is for Sumit. And that is to help us think to what extent have financing architectures that could include result-based mechanisms, any vertical fund structures, donor-driven conditionalities, to what extent have these functioned as constraints on fiscal sovereignty and on national health policy making? And who benefits from that arrangement or who doesn't?
Yeah. Thank you. Thanks for it's quite a broad terrain that your question picks up. But since we are trying to nudge and think around a political economy framework to it, for me, whichever my lens, as Joe was saying, like it's good to have a framework and to ask the questions. For me, it's very simple. When whichever health reform question is, I see how does it disturbs or how does it changes the consolidation and distribution of power and incentives. So that to me are the two key entry points to interrogate any question on that. When we talk of these lines where there's a result-based financing and development assistance for health, vertical finance funding, any of that. Now, what traditionally they do is two things. On power, it tries to create new constituencies of power. It could be multilateral organizations, could be development finance, could be international organizations, foreign governments. So in one sense, and this is very important, it sort of distracts the locus of power from the context where it rises to something else. It could be external, could be foreign, which creates very new dynamics to it. Or even if it is like, as Joe was indicating, as the private sector role coming in, then it sort of recalibrates or nudges the locus of power towards new areas. And I'll hold it for a moment. Similarly, when you talk of incentives, and normal incentives are distributed in the typical, it lies embedded in social contract. In politics, we think of or in wider public policy, we think of a reform as being corresponding to the more fundamental social contract. Now, when a new architecture or architectures are created, it sort of, again, similar to the power, it creates or distributes the incentives. Now, it's conceptually, it's not wrong if you are redistributing incentives, because at the end of the day, as from a welfareist point of view, we would like to see where does the incentives ultimately stabilize. If the incentives stabilize with its gains among the core stakeholders, which are the population and notionally the health ministries, and in somehow it redistributes incentives in a way where at the end of the day, the distribution remains relatively settled, it's fine. But the problem for things like vertical funding, and it's not always national versus international. And we have seen this enormously. Like, of course, there are very good returns. We have seen vertical funded programs like the Gavi, like the Global Fund, like Malaria Initiative. There has been tremendous success across the world in having these programs, and we know very well in the financing world that these programs, vertical funded programs, have their merits. But if in process of reallocating the incentives, it takes the incentives away and distributes to new groups, for example, in very traditional in microeconomics, we talk of contract theories. Now, if the social contract moves more towards individual contracts, and then a new rents that come up place, like I won't call it corruption, but new forms of rent that ends up with bureaucrats or other technocrats, that could be a problem. Finally, every of these programs, which I love talking whenever I go, I try to drag things to that, is the notion of political settlement, which we all know that political settlement varies in context. Now, in mature countries, even in the LMIC world, we know there are varieties of this kind of political settlement. Tim Kensel and others have come up with new typologies to talk of it. But I view where there is the institutions, as Joe was again telling, the other box. Now, if the institutions are weak, if the property rights are not well defined, then the problem, we call them as limited access orders or developmental state, whatever way people in politics are familiar with that terms. But in those kind of settings, it could be a problem. So, for example, if a result-based funding or a conditionality is built in a country, in a context where rules of law, property rights are less stringently defined, institutions are low, it could cause problems. I'm not even talking of ideologies that can bring a whole can of worms. But so it's difficult to say whether conditionalities means a good or bad or value judgment. But again, it's the distribution and redistribution it does would help us. So whenever somebody would like to assess, and these days with the whole dwindling of development assistance, whether it is good or bad, or risks or gains, should be viewed from the distribution of power and incentives and the institutional context this corresponds to. I would probably end there, and then we can pick up.
Thank you. Zubin, the next question is for you, and actually does pick up on a few points that Sumit has raised. So for a long time, development assistance for health has been framed as solidarity. But I think one of the questions that we have in our mind is how much of it is kind of in practice a strategic vehicle for what are effectively donor interests. And as development assistance for health is contracting, are the instruments that are now emerging in its place producing similar dynamics under new terms, or is it a completely different landscape?
So thank you for this question. Yeah, it does pick up with some of the themes that Sumit mentioned about ownership. But I think this question is important because it interrogates a very powerful narrative in global health today. that development assistance for health was until recently largely driven by solidarity, and we are the sharply contrasted transactional present. And I think this framing is driven partly by nostalgia, but it's problematic for several reasons. I think firstly, it's historically inaccurate. Strategic interests have always been central to development assistance for health. Second, it risks obscuring major weaknesses of the previous aid system, particularly unequal power relationships and inefficiencies in aid delivery. The third, it presents what's happened in the last year, particularly 2025, as a complete rupture rather than as a moment which has rupture and elements of continuity. And it also prejudges how countries may navigate these newer instruments. And I'm not just talking about the America First bilateral agreement, but about broader instruments, increased co-financing, and the agency that countries are demonstrating in navigating this world. So building on each of these points. So first, I think we need to be clear that some of the greatest global health gains, and Sumit made this point, have come from vertical programs or even programs closely linked to donor strategic interests. And PEPFAR is a clear example, credited with saving more than 25 million lives globally. US soft power exemplar in Africa, also framed with the national security paradigm, at least at the outset. So the point is not there was no solidarity, but that solidarity and strategic interest are often intertwined and linked to each other. The second point I made about viewing this through the lens of solidarity also sometimes obscures us seeing the problems with the previous aid model. And again, in the current environment with the financing crisis, I think that has also come to the fore. That much of the old aid architecture is described in partnership language, but were these really partnerships? And were these partnerships amongst equals? Donors decided what programs what would come on the agenda, what solutions were the best solutions, how programs would be implemented, and really had a control of what was going on. And then there were also significant inefficiencies. A large share of assistance was going through contractors, consultants, suppliers, often linked to, though not in all cases, linked to donor countries. And again, none of this is to deny a lot of what the old system achieved, whether you have this question of smallpox eradication or PEPFAR or TB control. Development assistance has played a very major role. The third point I made is about binary framing, not distinguishing what is genuinely new from what is a continuation, even if in more exaggerated form, what was earlier there. So continuation of donor interests, agenda setting power, asymmetrical bargaining relationships. And what's of course different is in the speed and scale. And we've seen the sort of collapse of health systems because the scale at which things have happened, the speed at which it's happened with a lot of uncertainty, the more explicitly transactional language, and the degree to which fiscal pressure is being shifted to countries. And for instance, transition and co-financing are not new ideas. They've been going on in Gavi and Global Fund for over a decade. But what's different is the rapid, as I said, compression of timelines, and a very great recognition of the fiscal constraints that countries are facing on account of aid contraction. And the fourth point I was making was about the risk of viewing countries as passive recipients and solidarity as being something between high-income countries showing solidarity towards LMICs in the old framing. And I think here we need to look at how countries are actively reshaping the health sovereignty agenda, including through regional solidarity and domestic political choices, which are often counterintuitive. So we see Ghana as an example, very prominent in articulating the need for African ownership and health sovereignty through the Accra Reset, and their stance on the US bilateral agreements, not taking up things which are not seen to serve their own interests. I wouldn't be sanguine about this, and I think we need to take very seriously some of the risks of the current shift. Many countries, particularly low-income countries and FCV settings, may not be able to absorb these new fiscal commitments that they're being asked to. We also need to understand the distributional consequence. So what services are going to go within countries and how countries are going to make those choices within if they're asked to make these choices, and how that's going to affect equity within countries. So there's a question of which countries are capable of this, and also within countries who's going to be more affected. And that matters because a lot of development assistance did, and look at the Global Fund, for instance, go towards marginalized populations who may not have been reached by domestic political systems if the domestic political economy were making those decisions. So I think we need to carefully distinguish between country contexts and the differential impact this may have across countries, and also the impact it'll have within societies. So I think the question is not whether the old model is solidarity and the new model is more transactional. There was always a mix of solidarity, transactional, and strategic interests. And we should test emerging arrangements by whether they shift power as they shift costs, and this comes to Sumit's point, how they serve to protect equity and maintain the equity gains, and whether timelines are realistic for different country contexts. Thank you.
Thank you so much, Zubin. I think I'd like to stay a little bit with the political economy direction that the conversation is taking, and ask Michelle the next question to reflect a little bit on the fact that very often reforms, whether in health financing or outside of health financing, tend to be politically led rather than being sort of technical failures. And so, in your opinion, what do you think are institutional or political economy factors that determine whether forms will produce genuine change or would be slower at achieving them or not achieve them at all?
Yeah, thanks for the question and fantastic reflection so far. So I really enjoyed your response, Zubin, and the points about interest and power, right? I think that's really spot on. So I would maybe sort of answer this question by going through some of the questions that I would pose when considering one of these reforms. And so one aspect is who is driving it? Is it externally driven, or is there real demand for a health financing reform or any health system reform really? Is it coming from the population itself? Because that'll tell you a little bit about the interests that are at play. And naturally, when something is externally driven, then the sustainability, the ownership is lower. So whether there's really a population demand for it. Now, when does a population really demand for changes in their health financing or their health systems? Links often to where the population feels a responsibility is for that provision of healthcare. And I think if we look at, say, the UK versus Pakistan, where I'm from, there's such a huge difference in between what the average person expects from their health system. Over here, a politician touches the NHS and that can cause them to lose an election. Whereas in many countries, health is not really an issue that it's petrol prices or the price of food. So where health features in terms of importance for a population ties to who often is driving those reforms, right? So one question is about who's driving the reforms. The second one is about accountability and whether the promised reforms, what is it that they're stating that they'll do, and what are the mechanisms for the politicians or the drivers to be held to account. If we go back to some of the reflections that Zubin shared about the bilateral deals, we see that the differences between how, say, African countries have responded often has come down to the strength of their civil society institutions in being able to challenge some of what's been proposed, say, by the USA, their media, and also their own ministries and institutions in being able to formulate evidence-based policies and really negotiate those power structures. So I think the accountability also then plays a huge role in determining who's in the driving seat and ultimately who the reforms serve and how long they last.
Great. Thank you so much. Zil, a question for you now, slightly, helping us think through some of the nitty-gritties. And that's related to innovative financial instruments that we are now starting to talk more and more about. So, for example, it might be blended finance vehicles, private sector partnerships, impact bonds. These are really being positioned as the kind of next bits of key global health financing architecture. What, in your opinion, whose priorities do these instruments actually reflect, and who would bear the risk if they were to fail?
Thanks so much. So for my PhD, I'm studying the political economy of health financing reform. So I'll try to do this justice. But as we all know in this room, and I think also those joining us online, donor financing has rapidly reduced across different LMICs. But then, so we've seen USAID being gutted just recently. We've seen European countries, ODA for health also reducing rapidly with the changing in priorities. And despite this reduction, people still need to access healthcare. Governments still need to mobilize revenues to ensure people have access to these different healthcare services. And so when this changes, they have to find this money from somewhere else. Sometimes it can come from the remaining donors. It could come from the philanthropist or philanthrocapitalist. It could also come from private capital, private sector. So when you look at this, because we are seeing this big gap in financing, we're seeing more and more approach towards innovative financing mechanisms. So this is an umbrella term for things around blended financing, impact bonds, private sector partnerships. But then the whole idea here is to be able to attract private sector capital. And if we look at that, we have to be aware that with private capital, there's also interest and incentives coming also on board. And there's a clear need for returns. So then whose interests are these going to be serving over the long term? And when you look at these different mechanisms and instruments, the whole idea is about being profitable. It's about being scalable. It's about being measurable. So often the interest of the local populations is not taken too much into consideration, because at the end of the day, the private capital needs to get back the money they've invested into these different mechanisms. So when thinking about whose priorities really matters here, it often is those who are putting in the money. And if you look at across the board, they often come from the global north, the high income countries. And so I would say that it doesn't necessarily consider, or maybe to some extent, but the LMIC population's health needs at that point in time. So I want to look at an example in this case where we'd see how such kind of partnerships can perhaps impact different countries. And we've different speakers have talked about the America's First Global Health Strategy. And I want to kind of like piggyback on this, because I'm from Kenya, and we've seen how Kenya was able to was the first country to actually sign this cooperation framework, and how we've seen this play across different institutions. Because I would say, though we've built strong institutions, there are still challenges here and there. So the America's First Global Health Strategy is not a blended financing necessarily, but it gives us a plan, because there are opportunities, for example, to open up the market for America's private private sector to then come and invest in Kenya, and I guess other countries as well. And so one of the things that it talks about is it reframes, or it requires countries to increase the health spending in those various contexts. So Kenya's cooperation framework, for example, it requires Kenya that it needs to increase its health spending 5-fold in 4 years. So a country that over the years, the IMF has been saying that Kenya is at a high risk of debt distress. It's really a shame to see that this new requirement for them to be able to kind of like raise this money and use it for healthcare. The second thing is, like, even if they raise this money and use it for healthcare, the needs for this specific requirements for America's First Global Strategy is on America's priorities. And in this case is around infectious diseases. So we see HIV, AIDS, malaria, and TB. Is that really Kenya's priority, for example? Is that really what we want in the country? I don't think so. We have like much bigger issues. I know these are key issues, but there are other things that we would like to see being considered. So if you look at the overall way this has been taken into consideration, you see the priority of the big funder here being America, calling the shots in how we are able to kind of finance our own health sector. And also, I think the call for the increased use of American innovation and American private sector interest, I think is quite concerning. But then I think there's a way you can look at it that, there are different powers involved here, there are different incentives, there are different interests here. But are we really seeing the voice of the local person in these discussions? Thankfully, we had our different NGOs come together and push that we need to have a clear idea of what exactly was negotiated in these agreements, and potentially to see if we can have anything else coming out of this, and to see how powerful actors, when they are involved in this kind of initiatives, and how the local population tends to lose, is also seeing the current Ebola crisis and how Kenya is already fully on board, wanting to help America again. So I think what Michelle is asking, whose interests are we serving in these cases? Who is calling the shots? Are the people even being heard? And when this is going on and on, at the end of the day, the public health, the population health is tend to be at risk. So while America is trying to keep itself safe, I don't think we are trying to keep ourselves safe. So I think so many questions being raised here, but I've tried to delve into it, I think, a different way, because I'm looking at it from a larger perspective beyond just the blended financing, because this shows how this is going to work across the board. This America's first strategy shows us how powerful actors can come into different countries and have their interest play. And the same thing happens to the private investors also come on board, because they still are wielding the capital. So they're going to also have their interests prevail, while the other people who are going to suffer the consequences often remain unheard. Yeah.
Thank you. That's actually very insightful, and then leads us to our next question for Professor Juliet. Professor, in your opinion, can regional institutions, for example, Africa CDC, PAHO, offer a genuine alternative to bilateral dependency? And what do you think might have to change politically and institutionally for that potential to be realized?
Thank you so much. I think I'll start by saying that indeed they hold significant potential, but currently they function more as complementary mechanisms rather than full substitutes. And realizing their full potential indeed requires substantial political and institutional reforms. And maybe I'll talk to some of the potentials that that we can appreciate. And maybe I'll single out, for example, access to medicines, vaccines, and medical supplies. The usual approach of partners bilaterally strengthening national medical stores. And there are some of these challenges that can be mitigated through a regional approach. For example, look at the area of procurement. The voluntary pooled procurement offers several benefits. The collective bargaining power, aggregating demands across countries, enables stronger negotiation positions. And as such, procurement of vaccines and essential medicines and technologies, we can realize savings from that. For example, we have some estimates from the SADC region that shows that this approach can actually reduce the cost of essential medicines by 15% and the cost of vaccines by 27% if it's anchored at the South African Development Corporation regional approach. So this helps us to cut out the middlemen, and even in Namibia alone, by cutting out the middleman, without even going through the regional approach, managed to save over 200 million Namibian dollars in just a space of 6 months. So it offers potential in that aspect. But also the other one is the registration of medicines that can be protracted. Building capacity at a regional level shortens that road significantly, but also reduces administrative costs. And we can talk about other things. For example, a regional approach to strengthening research capacity, the approval of clinical trials through regional economic communities can shorten the length in country-specific approval process, which is very important, especially in emergencies where we need to do these things fairly fast. A regional approach to strengthening human resource, the harmonization of education curriculum. This is also can enable the movement of labor across regional economic communities. And there are some efforts in that line, for example, in the East African community that is already happening to harmonize the training curriculum such that if a doctor is qualified in Uganda, can just go to Rwanda and practice. That can mitigate the human resource constraints that are really hampering our efforts towards UHC. But despite these strengths, the ability to act as full alternatives remains constrained. Many regional bodies continue to rely on external funding themselves. They have limited enforcement authority and face gaps in technical and operational capacity. So the political and institutional reforms we have to talk about must speak to these challenges that really affect their effectiveness. I want to speak to the political changes required primarily. We know when the regional economic communities, or even the Africa Union, or even Africa CDC, there's assessed contribution that countries must pay. And of course, it's a political decision to make sure that you meet your commitments, but also the willingness of governments to adopt binding agreements. I've been in research discussions on the continent in several of these, and every time we talk about harmonizing ethical review, countries say, no, we have country specifics. So I think we need this shift from prioritizing national sovereignty to embracing regional solidarity if we are going to really realize the potential these regional entities can put on the table for us to do things more efficiently and faster. But also, the regions must have the capacity to define regional priorities. And then the partners can align to that. And what does this mean? We must have the data, we must have the evidence, and we must be working together to make sure that we come to agreed regional priorities that can improve health outcomes in the areas that are anchored around any regional economic community. But also an evidence-based approach to defining regional priorities can help us politically insulate technical functions and make sure that we move towards the real benefit to the population. Now, I want to speak briefly to the institutional changes required. The unreliable funding situation is a big challenge because these regional entities cannot attract and retain talent. You will need this strong talent to make sure that our technical and operational capacity is effective to support the member states. Much of the human resource, even in Africa, CDC is funded by donors. And of course, these leave as soon as the donor funding dries up. So that does not help us to build institutional memory, institutional capacity, and consistently working towards what we want to see. But also, these regional bodies need to be funded more efficiently and more than what they are getting now to really move beyond just providing normative guidance, to have a leg in implementing the guidelines that are defined at a regional level, to have a leg in monitoring, to have a leg in service delivery. Because providing normative guidance is left to the individual countries. They may take it up, they may not, especially if you don't have funding to support them beyond the dissemination of the guideline. Another institutional change that we do need is the enforcement of mandates. The mandates of the regional bodies, for me, the definition of who has what mandate is blur. There are overlaps in mandates, there are overlaps in roles and responsibilities, which limits their effectiveness and the coherence in supporting countries. And also, so in a way, it also creates fragmentation and inefficiencies in the way we do operate. Because, for example, when you look at Africa CDC and also look at the WHO African region, we are both developing guidelines in the same areas. We are both building capacity, targeting the same people to be trained and in the same areas. So I think we need a clarity in roles and responsibilities in mandates and to be clear who does what, such that we move progressively. But also internal organization. For example, when you look at the regional economic communities and in Africa, there are some countries that are part of the South Africa Development Corporation, but they're also part of the East African community. So for guidelines that are anchored at a regional level, then such countries will be working with the two guidance documents, which makes it difficult to operationalize at a country level. And maybe that's why they fall back into country specifics, yet there is regional guidance, because these can work in conflict and it's difficult to have them enforced. And I've talked about the issue of data. I think we need to emphasize this, investment in regional data systems to support shared surveillance, shared capacity, research building, conduct of research, and also decision-making processes. So I think as I conclude, I want to emphasize a few things. That transformation requires a shift from donor-influenced coordination platforms to member state-owned platforms that are supported by donors, well-funded and technically robust institutions that can attract and retain talent and support beyond just developing normative documents, sustained political will to abide with agreed regional positions, but also to pay up assessed contributions and institutional strengthening. So if we can move in that direction, then the regional entities can offer a genuine alternative to bilateral dependence. Thank you.
Thank you, Professor. I think just to close the kind of formal panel discussion, I'd like to invite all the panelists to reflect on the fact that the WHO is about to undergo leadership transition. What would it mean for the organization to genuinely support health system sovereignty in low and middle income countries, rather than falling into a situation where the same dependency relationships get recreated?
Yeah, sure. I gave this some thought. So obviously there's many answers. I'll stick to one. Assuming there's a clear mandate and there's a strong WHO remains, I think one really valuable contribution it could make is to play a coordination role with its member states to have a much clearer agreement on how aid should be given, but also how aid is taken away. If we carry on with the same rules of disengagement after seeing the real harm it can do, I think that'll be a real failure. But naturally, it's very difficult for countries to coordinate. So even without a huge amount of financing, I think there's a practical role the WHO can play in terms of coordination.
Thank you.
Yeah.
I can see Joe's hand and then Sumit. Joe, please go ahead.
Yeah, just favorite topic of mine. I used to be in charge of complaining at WHO. I think there's a couple of things. One is, in a sense, if you take this agenda seriously, right, about WHO as an institution that is going to support domestic health systems of the member states. In a sense, it means, in some level, saying, what would you do if there were no donor? Like, if you're only relying on yourself, how would you organize things? And one part of that, and one problem in the past, has been that, in effect, nobody's been really in charge, in the sense that you have lots of strategies that come from different departments and that conflict with each other oftentimes. And, it's not just a current, leadership of WHO. I was in the organization for almost 30 years. It's a longstanding issue of an unwillingness to kind of say, this is our agenda. For example, you have, everybody supports primary healthcare as a strategy, but there doesn't seem to be a willingness to see through what are the implications of that, because at the same time you have that and, a focus on integrated people-centered care and so on, and that should be the core of your health system. You also have a promotion of very disease-specific strategies as well, and they're not consistent, but beyond the rhetoric around primary care, actually seeing it through from top to bottom of the organization to say, if this is our direction, then this is how we're going to move. And that means we have to change how certain parts of the organization do business. Nobody's really ever had the courage, maybe since Dr. Brundtland, nobody's really had the courage to kind of say, here's our strategy, and, sorry about the old way of doing things, but we're actually going to move in this way now. And without that, it's very hard to see how the organization's really going to be credible, because it all depends on who your counterpart is. And it also affects donors, frankly. I mean, the example that I was thinking of was that even though WHO is not a donor, to the extent that, for example, the Global Fund relies on the HIV and TB programs within WHO for support, there's a kind of almost collusion there. That's been a concern, right? Because money flows from the Global Fund to WHO, which is not what it should be if WHO is meant to be providing independent technical support. Even my program got money from Global Fund, so I'm guilty of this as well. I was guilty, now I'm not anymore. But I mean, the issue is, it's a concern to really kind of have the independence of the organization be a real independence, and to kind of say, whatever strategy is decided, you actually have to align consistently behind that. And that's just not the case. It's not been the case for a long time. Thanks.
Yeah, I think, of course, it's very little to add after Joe reflects on WHO, isn't it? Like, you don't have any. But I think I'll probably take it in just 2 points, but a little bit one step back. We are in an increasingly fragmented and fractured world. And as the tidings say, it's unlikely to lessen. It's probably get more higher. So one key area which the very little I do collaborate with colleagues in WHO or with other organizations is that to bring even within regions of WHO or in these groups, how we could build the kind of, we have been talking about solidarity, but even like small regions, South Asia, we know like the countries of South Asia hardly speak to each other in the way it should be, or even other regions, EMRO, for example. Now, there is one, it provides a very valuable regional platform to make appreciate how common questions like primary care, epidemic control, or even issues where this transboundary, we're talking of Ebola and we have already COVID behind, how within these regions we could, well, we can always talk of global, but at the end it's happens in the small regions. So that's one area where it provides a platform where it can build together. The other point is a little bit quite opposite to it, is I think the role of WHO bringing the global knowledge to the countries where they advise probably needs to be more politically adapted. Always it has been, but more so to the prevailing political language in those countries. I mean, it could be tenuous questions of PHC or big ticket insurance, health, human resource reforms, or some other domestic resource mobilization or donor aid. I think to kind of nudge and put the language towards the current question is also to kind of uh, stabilize its relevance more. So in one way, providing platforms for more regional coordination when most, I mean, Juliet was saying, like regional groupings, indications of fraying, internal tensions. So the regional platforms on the one hand, and sort of calibrating to the national language of the dominant political language on the priorities, I think is been pretty much always there. But as you say, like now more than ever.
Professor Juliet?
Yes, thank you. I think for me, I would speak to two areas. One, what do we finance and how do we work with countries? I think now we need to be very intentional about building the capacity of countries. We have already said there is no capacity, but actually when your intention about it and you really look, there's a capacity you can strengthen. Even if it's not significant strength. I mean, we've been training years, we've been building capacity years. Why are we stuck in this? It's because we are not intentional about it. We need to bring universities in the place where they belong. We need to harness the capacity there is. It may not be in the ministry, but it's within the country. We need to bring this at the forefront to champion the implementation of whatever it is that we are supporting to implement ourselves, whether WHO or any other partner. I think we've come to that. But also, we need now to be committed to what we've agreed on before, for example, the Lusaka Agenda for Action, and the long story right from the days of the Accra Agenda for Action. How do we engage countries? I think we need also to strengthen the component of accountability. You know, if governments are not accountable, they will not be accountable in all aspects, be it financing, be it service delivery, be it use of evidence. So how do we hold governments accountable? Once they are accountable, they will have the right managers in place. They will make sure they have strong human resource policies that are implemented. They will make sure they are efficient in their allocations. And then I think that is more sustainable and it minimizes our coming in and out, which has been the long story of consultants flying in and out and no residual capacity left in the country. I think let's bring countries at the fore of this. Let's harness the potential that they have. Let's hold them accountable. And I think that way we can be more sustainable in whatever we are doing. Thank you.
Thank you. Any final reflections from the panelists on that?
Yes, so I'm happy to go as a WHO outsider. And even when thinking about the WHO reforms, these reforms will still be happening within a political economy context where we have the biggest funder who's just walked out where we're seeing countries signing bilateral deals, with the US, for example. So this leaves some countries at a very complex kind of like situation. We're seeing there'll be less of collaborative bargaining amongst these countries because it's more fragmentation across the board. At the point when they need this coming together the most, now we've seen the case of Ebola. And so as we think about where the WHO is going next, I would say, for example, I just hope to see more voices from LMIC context and not just consultations, like more involvement decision making across the board. Yeah.
Thank you. I think what we'll do now is open the floor for comments and questions for our guests in the room and people who may have joined online. And I think I will rely on Tamar to help pass the mics around, and I'll just have a look with Hinsa for online questions. Just to say, Michelle has to leave like in 2 minutes. So if anyone has a very quick question for her in person or online, we could take that first, and then we could free her up for her next commitment. Sorry, I've just put everyone on the spot here.
Yeah. No pressure. If there's no questions for me, it's okay.
Ask me something. Stop.
All right. So questions from the room, comments? Yes. So we're very fortunate to have with us Dr. Lola Derry, who has been an experienced health system finance expert and really has been advocating for sovereignty in low and middle income countries as far as health financing is concerned for a very long time. So just would be very welcome to have your reflection.
Thank you for inviting me to a delightful discussion, and with many friends, Joe, Juliet, and footprints along the way. Are we failing forward, or are we putting new wine in old skins? I think it's a question that is running through every discussion I've been through, every panel I've listened to. Is this a new discussion? And Joe is referred to it, Juliet is referred to it, and quite a number of people have referred to the IHP, UH 2030, Harmonizing for Africa. Have we not had these discussions before, and what is new? What are we going to do differently? And that's what I would like to ask each of the panelists to think about, not just today, but as you advocate across board. What are we going to do differently, and what are we doing differently? I was very fascinated by the power relationships. Of course, this is financing is a technical and a political issue. And when there's politics, there's power. And this power is not just between countries, it's within countries and between governments and their citizens. So it's very delightful to hear Kenya saying, we need the voices of citizens, we need the voices of civil society. So what is going to be different now is that we're going to go from a technical decision, a power decision, to what I call resilience. The failure of the past is that we are not resilience ready, whether it's domestic financing, whether it's international financing. We fund our little corner without funding the systems that will keep them sustainable and resilient. So Gavi is trying to transition, Global Fund is trying graduation, but it's falling down because, like Juliet has said, the resilience of countries is not built as part of the domestic or international funding. If we don't build resilience, we are going to be having the same kind of discussions. So we propose this certain shifts. Financial sovereignty, the test of the pudding is in the voice of citizens, their access and trust of the system. If they don't trust the system, if they don't have access to services, there's no sovereignty. Whether it's financial, political, or economic, there's no sovereignty. So how are we going to build into the new narrative that we have voices of people, voices of systems, and voices of civil society? Civil society is really challenged at this moment, really challenged, for the same reasons. We funded distribute bed nets, but not the system to distribute bed nets and purchase bed nets. We funded distribute ARVs, but not the system of countries purchasing ARVs and making sure that it's sustainably available. So I'm pushing my colleagues in civil society as well. How do your institutions remain resilient in the new sovereignty as we discussed it? Thank you.
Sure. So I really agree. And I think going back to your first question, what should change? I think now, as distasteful as it's been, some of the transactional nature of agreements in health allow things to be more transparent. And this gives an opportunity for things that were maybe perhaps hidden in terms of interests to be surfaced. So if I'm trying to find some optimism in this situation, it's that now we can no longer say, oh, we didn't realize that this deal was all about our mineral resources, because it's being said very clearly, and there's some power to the people in that transparency now. If they can hold their governments to account, that's the next level. But there's an opportunity in the distasteful, naked, transactional direction that some of the deals are going in.
Yeah, I mean, exactly. I think what Ms. Hall was saying, but I think to me, the way I view it is, and I'm very thank you that you have brought the conversation or the question not just between countries, but within countries. I come from India, which is a, a continent in itself, like with the different, you bring the federal challenges, the tensions everywhere. And I think, and I also have worked very recently a bit in other big countries like Brazil or Mexico. And what I always find, and I think the missing link which we still have, I don't know how, but the questions of health compared to questions like employment or you know, probably economy is still not been in the political language of the countries. So election, I mean, as I think Jill mentioned, like the big difference still between the political currency in the high income countries in the West and the low and middle income countries in Asia and Africa, and bit in Latin America. Latin America is a bit ahead, I would say, in that still, is that with Brazil's right for health and things like that. But we have not yet been able to bring the questions of health, primary care, financing, insurance, into political language. These are big democracies, quite intractable several challenges. Most countries, large countries, have retained their democratic electoral competition in some form, but still the questions of health have been at the periphery. So as long as we are not able, in democracy, in political systems, the solution lies in politics. It had to be in politics. Even when, so when you talk of civil society, I would say, is the civil society able to bring the question of health from periphery to the mainstream, where that becomes a question of political debate and a question of where elections are fought? That probably to me is the kind of connectivity gap we probably need to make up.
Thank you. We've got some hands up amongst our online panelists. Zubin, could I invite you to comment?
Yeah, sure. Thanks. So just reflecting on this discussion, I think one is, of course, the fact that we've seen that health has clearly come as a result of the shock, the immediate aftermath, which we saw in countries as diverse as Nigeria, South Africa, Ghana, of health coming onto a broader, not beyond just the health ministry political agenda. And I think that just because the shock that did come at that time, suddenly there's been this budget shortfall, did help to stir some of that. Now, how that gets translated into further action, we have to see how these initiatives, such as the Akrari said, finally pan out. The other thing I think is that there will be accountability will be built through this, right? If countries are not able to, this time it's almost a challenge, is this time the transitions are probably for real, right? I mean, we've been talking about transition very long and you have extended timelines. Now, when countries are forced to do this, is it going to result in increasing the actual accountability of governments to their own citizens? And I think this is where bringing civil society pressure, that this is a moment where you can no longer go to a foreign donor, and you should not be going to a foreign donor. And I think it's important for civil society to capitalize on this moment that is currently there, where you have this sudden shortfall of donor resources, and you have this priority being given within countries to put in increased resources for health, at least the statements. And how do we actually transfer these statements into actual concrete action by the political class in each of these countries? Over.
Thank you, Zubin. Joe?
Yeah, I just wanted to respond to the questions about that we're not building resilience and what do we do differently? What's the same? And what I tried to convey initially is what's the same is our general messages on financing of health systems, but what needs to be done differently or looked at more broadly is that now I think countries need to take both the capital financing issues more explicitly on the agenda and to look at the issues around um, the, the financing of the inputs, not merely as a health issue, but really almost as health as an economic sector. So what is the potential there in terms of jobs, of, development of that industry, as well as reducing some foreign dependence. So I think that part is a bit new, at least, I mean, it's new to me. I mean, it might not be new to others. I don't know, in terms of taking that seriously. And on the resilience issue, I've taken this really as a question of literally the ability to adapt and change. And to do that, one thing where the international community has failed, I think, in a way, is that we've had things, like with the SDGs that are driven by lots of, indicators, quantitative indicators and measures. And there's nothing about institutions, there's nothing about adaptability, there's nothing about reliance in that sense. So I think what we probably all need to do, but really starts with countries, is investing in your own brains in a way, making sure there's a place in the health system where people can learn, can interpret their own data and use it to adapt. And I think that's critical. There are things you can do system building to support that, like building more unified or interoperable data platforms rather than things fragmented by scheme or disease. And maybe there's an opportunity to do that now. But I think these are things that are a little bit different. At least the momentum hopefully is there, and it's really important that that movement happens. Thanks.
Thank you. Professor Juliet?
Yes, thank you. I like Laura's question very much. And I think if you've been around for some time, you can get frustrated in these discussions because each discussion, the conclusion is as what you've said many, many years ago. Now, she touched on the issue of accountability, which actually is also not new because from the old days of sector-wide approaches, we've talked about code of conduct, MOUs, and all those instruments. Of course, our shortcoming now looking back in those days was we focused so much on donors being accountable and we didn't put enough effort in governments being accountable. But having said that, I think now the kind of evidence we are looking for is why haven't we done what we are convinced is the right thing to do, as opposed to looking for evidence that says what is missing. No, we know what is the right thing to do, but why aren't we doing it? I think we need to change that and look at those underlying problems that are stopping us from doing what we think is right. But I want to come back to the issue of governance. I think for me, one thing is our limited scope when we look at governance. Every time, first of all, we don't know how to build governance. And I must admit, because many times I'm in these countries in Africa, every time we say there's no governance, the response is, let's have short courses. So we've been training and still there's no governance. Having said that, I think governance is being looked at in narrow scope. It's not only the politicians at the national level, it is and as much as the health facility, head of the health facility, the medical superintendent, all of us have governance responsibilities in whatever scope, given the positions that we do hold. But we focus so much of the minister's not done this, the president is not doing this, the director general of health services is not doing this, but what are the health facility heads doing? Are they doing their bit? I think we need to look at governance at all levels, including the community level. What are the local chiefs doing to improve health? We look at governance all the way, health facility, national level, such that everybody is accountable in their spheres of influence. Some countries are moving into contractual obligations, but of course they are very far from that. And of course also enforcing them and monitoring them is a challenge because you need a huge workforce and a strong institution to do that. But I think it's a good starting point. But I think all of us have to look at it from that perspective that we all have governance responsibilities. Do your bit as we wait for the minister to do his or her bit. Thank you.
Do you have any questions
Yeah, sure. Thank you so much for the discussion. I'm hearing a lot of narrative around like moral based and value based leadership in this space, and it's been really interesting to hear the dynamics at play. I'm really curious, as a young leader in this space, kind of going into that kind of career path, and lots of us sitting in the room as well, interested in like with the withdrawal of like large powers such as like the US this January in 2026 from the WHO. What do those power dynamics look like in terms of decision making, strategic global? What if we have another pandemic down the road? What do we like? What kind of like what are we looking at in the next couple of years? I'm not asking for a magic crystal ball answer, but I'm actually genuinely asking as this is a very large space in flux. What do we expect if we're not actually following the playbook as a global as global players and leaders in this space? How are we doing this as like young leaders trying to emerge into this kind of evolving and up in flux kind of dynamic in healthcare?
Yep. Can I? Yeah, I mean, I think it's the things which I probably have mentioned before is that the big challenge is of course because there are newer tensions and pressures of getting it more fragmented. So more fractures and fragments are being done or happening. Now, very naturally, in a natural world, when there is more fractures, more fissures, more tensions to fragment, the first job is definitely defensive. So for new leaders or anybody with a new regime, the main challenge would be to stop the fragment, to stop any kind of unmaking. There is a lot of force towards unmaking things that we have done. Solidarity, we have spoken, collaboration, coordination. That is, to my mind, the first thing that we have to stop anything to getting worse. And on a corrective side, it's the same way to make it even more clear that the problems are far from being solved. There are new kids in the block as problems. And number two, the solutions, as it has been always, is in responding to them together. The problems in Colombia and Cambodia is not structurally different. They can look different in populations, but the problems remain the same, which are still the core global health questions we are grappling with. So emphasizing that our problems have common solutions if we work together, and to stop it from fragmenting and fracturing further. How? Well, Professor Lucy was saying that how we do that? How could we have been talking? And I think, again, the answer is to changing the narrative of politics. It cannot be done, advocacy change cannot be done by keeping politics at arm's length. It has to be politics. So, yeah,
Can I just add to that? I'm in the same boat as you, just finishing my PhD. So of course, it's something I kind of like worry about. But look at the framing that you've shared about, are we seeing, is it about old wine in new wineskins, new wines in old wineskins, or are we failing forward? So I kind of want to look at it in a positive way, that we are perhaps hopefully failing forward, that we are learning from this, that the more chances we're going to learn from this current situation, we're going to have like more opportunities to perhaps do something different than we've done before. So I do believe like upcoming leaders like us, like you, hopefully are going to join the others who are doing this already and do something different, perhaps to uplift the next coming generation. Yeah.
We have a question from one of our online guests, and that's related to the role of private pharmacy. So they asked, if private pharmacies are the first point of contact for millions of people in low and developing countries, why do UHC financing and health system reforms continue to treat them as peripheral actors rather than core components of primary care? And is the future of fiscally sovereign systems therefore dependent on a new social contract between government, communities, and private pharmaceutical providers?
Chair's mic isn't working.
And that might be better. So the question is about private pharmacies, which tend to be the
It's on, switched on.
first point of contact for millions of people, and why USP financing and health systems reform continue to treat them as peripheral actors rather than core components of primary healthcare.
Sorry, I can't hear you. I don't know whether it's only me.
What about now?
No, not well, but I do remember seeing the question in the chat and just maybe a brief reflection. I mean, I think the point is that if you know, in a way, whether services are being, many services are being delivered at private pharmacies or private providers or non-state providers, the people doing the work on that health system, so the people who are responsible for delivering services and funding them, need to adapt to where people are going, right? So that, if that's being ignored, and if, in a sense, the public sector is only looking after what it funds directly and what it controls, then it's not doing its job, right? Then the Ministry of Health's not doing their job. So it's a reasonable question to bring, is to say that if this is how service delivery works in your system, then you need to I think that it's up to the system to adapt to what that is, and to make sure that those, in this case, private pharmacies, are somehow integrated into the primary care system, they're reporting data, and so on. So I think that that's an important aspect of that. And to the extent that that's not happening, it's a problem that the system's not really doing its job. Thanks.
Thank you, Joe. Zubin, if you'd like to comment. Oh, I think you might be on mute.
Sorry, I just got it all ears. Yes, so I think a challenge here is that this is what the problem of governance being in ministries of health, often looking only at the part, as Joe pointed out, what they are responsible for. They see in many settings, you have them not really look at the private sector as their issue, and you have large parts of the population going there. So I'd really agree that you can't really have health systems governance that doesn't govern the private sector just because they're informal pharmacies or they're not in the public system. And I think that the future really will depend on a social contract that looks at the whole gamut of providers, irrespective of whether public or private. Of course, reinforcing the fact that we want to not move away from the core financing principles of not having these pharmacies be a source of impoverishment, and therefore look at financing arrangements that at least ensure that these people are able to access these without undergoing serious out-of-pocket spending.
Thanks, Zubin. Professor Juliet?
I want to make a comment on private sector in general. And of course, personally, I really support private sector engagement. But I think one question we need to ask is, do we have the right policy and regulatory environment to meaningfully engage the private sector? And do countries have the capacity to meaningfully engage the private sector? We've seen public-private partnerships that have gone terribly wrong. Maybe some of you have read about the case of a private hospital in Lesotho. I know that they definitely have a role to play because government cannot do it alone, but we should speak into what are the prerequisites to meaningfully engage the private sector. I saw a study one time, a country that conducted an assessment of the private clinics, and the conclusion was 60% were not registered and not even known to policymakers, and were providing health services. So I think as we move more towards a private sector, more engagement of these, we need to make sure that we have the right policy environment, we have the regulatory environment, but even the private sector has to be organized well enough to meaningfully engage in policy processes, in service delivery, and also we need accreditation mechanisms in place such that we can accredit the good private providers. We need all these guidelines. So I think just embracing the private sector without being sure of what kind of quality they are providing, sometimes they're even dangerous to population health. So I think I should make this point that let's first build the foundation for meaningful private sector engagement. Thank you.
Thank you. I think we've got time for one final question, and there was your hand up, so if you wouldn't mind asking.
Yeah, thank you very much. when I looked at the topic, it's quite sensitive, and it's an area that people try not to speak their mind, which is quite disturbing, because if you speak your mind, it's going to be like you are a critic. And we talk about politics, we talk about power and fiscal sovereignty. And what we saw with the American First is not transactional, from what I gathered from people from Africa. I mean, there's power dynamics here. Some have styled it to be bullying and harassment. Most African leaders were left with no choice. You either do it or this is a punitive honor. So the American First program is requiring extensive data of African people who are ill, and I get the news back home that, some school of thought have it that it's not just the billion that America will give to this country, because they will have to take it back through the production of vaccine and all sort of conditions. Professor Julian made a point about that it's not just about government. A friend of mine told me a couple of years, is saying that the fish smells from the head. So the minister and the president, they are accountable. So if the healthcare sector, they have to make a conducive environment for these things to gel. And Africa and low, medium income countries cannot continue in this day and age to be relying. The resources are there. There's a lot of argument. The resources are there that if there's accountability, if the West refuse to accommodate presidents that are corrupt, that have been shown in those countries not likable. Unfortunately, I'm from Cameroon, and we have a president that is topping the age now. And for some reason, the government is not functional, but it's one of the signatories to this American First program. So, I mean, the point I'm just trying to, it's a very sensitive topic that sometimes if you want to talk, you'll be seen as, you never know if your name can go into a database into like someone who is being critical of the words, but it's really appalling for some of us who know that the resources are there. You just need good governance, So that's my take. I just feel that these countries, they have the resources. Africa is so rich, they should be pushed to do things for themselves and not continue with this dependency, which we don't know when this will end. So that's a point I want to make. Thank you.
Thank you. Would any of our panelists like to comment? Dr. Dari? Yes.
May I?
I just want to drop a little bit of
Sorry, Professor Juliet, Dr. Dari is just going to comment, and then we'll come back to you before wrapping up.
I just want to drop a little bit of something into our consciousness. Financial sovereignty is not the only thing that's going to make us deliver essential services from the first to the last mile. It's part of a cocktail of a reform of the global health architecture. In this reform, we're going to have opportunities and pitfalls. But when we leave communities and citizens behind and we don't hear their voices, then sovereignty has failed.
Exactly. Yeah.
Thank you. Professor Juliet?
Yeah, two very short comments. I know we are finalizing. Perhaps the America First negotiation is one thing that would have benefited from a regional approach in a negotiation. Maybe that should have been raised at the African Union to really strengthen maybe vulnerable leaders, if I may use that for lack of a better word, but it is what it is. But I also want to come to a point related to this. I know at least 3 countries that have refused to sign those agreements. And maybe our colleague from Kenya can also talk to us that I think the people themselves went to court and there was some rolling around that. So what do we learn from each other? The colleague from Cameroon says it went the way it went, but also we know some African countries that have been strong enough to stand up against some of these things. But also collectively, how can we really strengthen our regional institutions to champion some of these very sensitive negotiations that can put individual countries in a very vulnerable state? Thank you.
Thank you. Joe?
Yeah, well, I'm glad to hear what Juliet just said about some countries refusing to accept this. I think it's very important to understand who you're dealing with when you're considering one of these agreements. You're dealing with the mentality of a criminal gang leader, right? Who will force things, and we've seen it even here in Switzerland. I think I wrote this that basically there's no agreement they sign now that they're going to not walk away from when it becomes inconvenient, right? So you have to kind of it's not that you will tell them this, and I mean I can say it now because I'm retired, but basically that you need to really take seriously who you're dealing with here and have no illusion. And in a way I sometimes put it as to whether is the hypocrisy of the past better than the brutality of the present, in a sense. And, yeah, it might still be better to be in the past. I don't know. But I mean, the point is we need to not go back to the way things were, but really take seriously who you're dealing with and not suggest that somehow you can negotiate something that they will live up to. Because if it's inconvenient, they'll walk away.
Yeah. Yeah.
Very true. And on that note, I'd really like to thank everybody, our online panelists, our in-person panelists, for their generosity and their time and for sharing their thoughts with us. It's definitely given, I think I speak on behalf of everybody to say that it's definitely given us more to think about. It's raised more questions, but hopefully these will be conversations that we carry with us and keep discussing. And as we've just reflected, it might give us something new to work on rather than reflecting on, oh, things have changed for the worse. So thank you all for joining us. And on a final note, I would like to acknowledge and to bring to everyone's attention the Collecting Learning Network, who are the co-hosts for this event. Every 6 months, the Collective Learning Network welcomes new members. So if you're interested in working in health systems and policy, please do speak to Etse and Hinsa if you're in the room, or you can scan the QR code that's on the screen now to find out more and join. So, and thank you again for joining us, for listening, for sharing your comments and your questions. And if you're on campus today, please do join us for some refreshments. And thank you again to our panelists.
Thank you. Thank you very much.
Okay. Thank you. Bye-bye.
Thanks. Bye-bye.
Thank you. Bye-bye.